Welcome to Emerging Updates in Depression Treatment, New Data in the Mix. My name is Manpreet Singh, and I'm joined by my colleague, Dr. Denise Vanacore, and we'll be talking about this complicated topic and hopefully unpack it for you for clinical practice. I'm going to ask Denise to get us started with a case.
Great. So we're going to begin by starting to look with this through a case discussion. So this is Carolyn. She's a 32-year-old female with a second episode of major depressive disorder. She's already restarted the escitalopram, 10 milligrams, and appropriately already titrated up to that 20 milligram dose. She had about a 30% improvement in her symptoms this far, and she's coming back today for ongoing residual symptoms that include daytime fatigue with some difficulty staying awake. In addition, she reminds you that she does not want to gain any weight on any medications that we use. So, can you get us started with some options for her?
A terrific case to get our discussion launched, Denise, and it is such a conundrum to know whether we ought to be starting a new medication for Carolyn or potentially augmenting an existing treatment. So to augment or to switch, that is the question. And oftentimes we're thinking about that with our patients, and patient preference is oftentimes a leading point in terms of our decision making, clinical decision making, as we do collaborative care with our patients. But some other factors might play a role. If you're thinking about switching, it might be after a single failed trial of an antidepressant that's poorly tolerated. Maybe you get less than 25% improvement in symptoms on that initial antidepressant, with non-response being something like that kind of a definition, less severe symptoms or functional impairment, or a patient preference to switch. An augmentation strategy might be preferred for some patients who've had maybe more treatment failures, or maybe two or more, where the initial antidepressant may be well tolerated. You get a 25% improvement in symptoms on an initial antidepressant, defining a partial response. And there's just more symptoms that are severe, that are at play, and might be very functionally impairing. The patient might want to add another medication to address those residual symptoms or side effects that are oftentimes present when you push the primary dose of the primary antidepressant. So if you can potentially augment the function and the efficacy of a primary antidepressant with an adjunct treatment, then maybe an adjunct or augmentation strategy is the right approach. I'm going to turn it back over to you, Denise, to get us started on the world of potential options in terms of switching and augmenting, and we'll take it from there.
Great, Manpreet, thank you. So for this discussion, we're going to focus our attention on the option of atypical antipsychotics that are approved for adjuvant treatment. So atypical antipsychotics are sometimes used for adjunctively treating major depressive disorder, especially when patients do not achieve sufficient improvement with antidepressants alone. This slide highlights the currently approved medications for adjuvant treatment. And these medications are typically used just in combination with a standard antidepressant to help improve those depressive symptoms that seem to linger. It's important to consider the potential side effects of these medications and discuss all the risks and benefits with patients before initiating any kind of atypical antipsychotic. We want to make sure that patients know every option available to them. So, Manpreet, will you start our discussion with one of these medications?
Sure thing. Let's talk about Aripiprazole first, a very common option for augmentation. Sometimes people might want or desire a switch, but we're, for the purposes of this discussion today, focusing on augmenting strategies. So how does Aripiprazole fare in terms of potential candidates? It's U.S. Food and Drug Administration approved for augmentation for refractory depression. Its mechanism of action involves partial dopamine agonism and serotonin agonism and antagonism. The dose recommended may start off at 2 to 5 milligrams with a target dose of 5 to 10. adjuvant again, and a maximum dose of 15 milligrams per day, generally speaking. It's metabolized in the liver by 2D6 and 3A4, and the side effects that patients often report are akathisia, restlessness, in addition to some GI side effects and sedation. So with those side effects, we have to be mindful that they may be dose dependent, and patients will potentially find those as being potentially dose and rate limiting. Nevertheless, patients who use adjunctive aripiprazole can experience significant improvement in their symptoms beyond their primary antidepressant. I'm going to turn it over back to you, Denise, to talk about our next option.
Great, thanks so much. So we're going to take this next few minutes and we're going to talk about the Olanzapine-fluoxetine combination medication. And this is approved for treatment-resistant depression, which includes cases where MDD has not responded to 2 separate trials of different antidepressants. The combination of olanzapine and fluoxetine targets multiple neurotransmitter systems, and this potentially offers a more comprehensive approach to treating treatment-resistant depression. So this combination medication can address both depressive symptoms and sometimes any co-occurring psychotic features or mood stabilization needs that you might have. Again, we're starting with an initial dose of 6 milligrams of olanzapine and 25 milligrams of fluoxetine a day, and moving upwards as patients tolerate. This medication is metabolized at the CYP1A2 and the CYP2D6. So we have 2 different areas where it's metabolized. It does have a few common side effects really related to having both medications in the mix. And sometimes the combination can exacerbate the side effects of each component. So particularly metabolic issues or even sedation. So I'm going to turn it back to you, Manpreet, for a discussion on our next one.
Yeah, so our next candidate for potential augmentation is quetiapine extended release. We know quetiapine well. It's dopamine 2 receptor antagonist and serotonin antagonist, and its active metabolite norquetiapine is also a norepinephrine reuptake inhibitor, which adds some diversity to the receptor targeting in the brain and also has implications for side effect profile. The dosing may start at 50 milligrams with a target of 150 to 300 as a maximum dose, and it's metabolized by CYP3A4. We all know that quetiapine can be very sedating. Sometimes that's actually a value for patients that are struggling with symptoms of insomnia and anxiety, particularly that result in initial insomnia, worries and frets that lead to difficulties falling asleep, can often be addressed with this adjunctive treatment. And the nice thing about the extended release formulation is that its effects can carry through not just overnight, but through the day following. Dry mouth, constipation, dizziness, appetite increases, as well as weight gain are some rate limiting side effects for some patients who do not want to have those untoward side effects, like Carolyn, who mentioned she doesn't want to gain any weight, might be a consideration for a medication like this. But generally speaking, patients who do elect to have quetiapine adjunctively have noticed some significant improvement in their depressive symptoms when used adjunctively with a primary antidepressant treatment. So back to you, Denise, for the next one.
Great, wonderful. So now we're going to talk about Brexpiprazole. So this acts as a partial agonist at the 5-HT1A and the 2D receptors, which helps modulate the neurotransmission and can help improve symptoms of depression by balancing both serotonin and dopamine levels in the brain. The antagonist action can help reduce depressive symptoms and improve mood further by regulating serotonin and noradrenaline pathways. Our starting dose here, again, is 0.5 milligrams to 1 milligram daily with a maximum daily dose of 3 milligrams. So compared to some of our other atypical antipsychotics, brexpiprazole may actually have more favorable side effect profile, particularly regarding some of the metabolic effects, but it does have that concern with weight gain. So again, with Carolyn, we'd have to discuss that option. As adjuvant therapy, brexpiprazole can enhance the effects of the antidepressant in patients who've not achieved that adequate relief from their depressive side effects. The action on the dopamine and serotonin receptors may also help to stabilize mood and reduce those symptoms at the same time. So I do think that brexpiprazole will offer a potentially effective option for her with treatment-resistant depression when used in conjunction with other antidepressants, with the caveat that we would watch for any kind of weight gain. And with that, Manpreet, back to you for our next option.
Yeah, I'm excited to talk about the next several options because they represent the next generation, if you will, of drug development treatments that we think are maybe a little bit more favorable in terms of risk-benefit profile, have had now even more diversity of coverage of receptor action, and relatively few metabolic side effects compared to some of the more traditional antipsychotics that we've described before. The first one we're going to talk about is Cariprazine. Its mechanism of action is a partial agonism at D2 and D3, and also with some serotonin agonist and antagonist activity as well. Its initial dose is 1.5 milligrams a day. The nice thing about this is that you don't have a titration schedule. You can just start patients on this and maintain them. There are a subset of patients that benefit from the 3 milligram dose per day, which is generally where you get the most bang for your buck. If you don't initially respond to 1.5 milligrams, the clinical trials suggested that anything beyond 3 milligrams is really reserved for a very specific or narrow patient population. The metabolite di-desmethyl cariprazine is the main metabolite, and it has a very nice long half-life. So it gives you a very nice long coverage over the course of the day, metabolized at 2D6 and 3A4, like many of the other options. And the most common side effects that patients report with this medication are restlessness and akathisia, with some fatigue, nausea, constipation, and insomnia. The weight gain really isn't as much of a problem for this one compared to the more traditional dopamine 2 antagonists because of this partial agonist effect on dopamine 2 and 3. And you have some dizziness and extrapyramidal symptoms in part because of the receptor action there. But a nice option for someone like Carolyn who does not want to gain weight and might be amenable to an option like cariprazine, either as a switch or as an adjunctive treatment. Turn it back over to you, Denise.
Great. So we're going to begin with these next two slides, and we're going to look at a medicine called Lumateperone. And this slide, as well as the next, are really going to look at two phase 3 studies that have been completed with Lumateperone regarding adjunctive treatment of MDD. So this is, again, an atypical antipsychotic used for the treatment of schizophrenia and depressive episodes associated with bipolar 1 and bipolar 2. In the phase 3 501 study, this demonstrated that we reduced the MADRS total score, the CGI-S score, which indicated clinical improvements in depressive symptoms. And this occurred pretty early in the trial at about day 8. On day 43, it showed significantly greater improvements, 9 out of 10 on the MADRS items compared to placebo. So this was a great study that showed us that this might be an up-and-coming drug for a new option for adjuvant therapy. On the next slide, we're going to highlight a second double-blind phase 3 trial Study 502, that was presented at the 37th Psych Congress. Durgam and his colleagues found that adjuvant lumateperone significantly improved symptoms in patients with major depressive disorders with mixed features of bipolar depression and with other mixed features. Lumateperone showed greater improvements in that MADRS scale compared to placebo on day 43, but it was most efficacious on day 15. So these two studies, both 501 and 502, were both phase 3 randomized double-blind placebo-controlled multi-center studies. And so this really helps us add an additional medication to the repertoire of considering adjunctive treatment for MDD. With that, I'm going to turn it back to you, Manpreet.
Isn't it so interesting that we're iterating towards better and more better tolerated medications, which is a win for our patients in struggling with depression. Next slide, please. So I would just like to thank you all for your attention and guide you to our programs. We're part of a larger program called Addressing Ambiguities Across the Psychotic and Mood Disorders Continuum. So we'll hope you'll join us for our other programs that are related to this activity. If you go to the next slide, you can claim your credit for this activity here with this QR code or link. And we thank you so much for your time and attention today and look forward to engaging with you in the future. Take care.